Hi, everybody. I'm Ken McLean, and this is Carl Allen, and hopefully our colleague Olive Eckstein will join us if she makes it through the traffic jam. And we wanted to give you some updates of our work in Houston, thanks to your generous support over the past many years, and just show you some things that we've done in the past 12 months. I think that one of the exciting things for us in our challenge, of course, that Ron gave us now 5 years ago was to cure all patients. So towards that end, we've been working on some new therapies for patients who've been very challenging, and I want to tell you about one of those today. Just to give you a little background, you know, there are many presentations of LCH, Langerhans cell histiocytosis, and it can cause horrible skin rashes that are painful and ugly. It can cause horrible bone pain by eroding bones and making holes in them or even breaking vertebrae, and it can involve the liver and spleen and bone marrow and lymph nodes. But one of the most challenging things that we're faced with is a neurologic problem, and there are kind of two aspects to it. One of them is that there are the pituitary gland is kind of the middle of our brain, and it regulates our thirst and also has hormones which help make the thyroid, the adrenal growth hormone be made, and also our sex differentiation hormones. So the pituitary involvement has been known to affect up to 25% of all patients historically, but in the LCH3 study that was published a couple years ago, with a year of therapy, now only 12% of patients are having pituitary involvement. So that's the good news, but there's still 12% who have that problem. But more perplexing is a condition where the disease affects the back part of the brain called the cerebellum, and that is responsible for helping us keep our balance, for allowing us to do things with our hands, such as writing. It can affect, if there are problems in the cerebellum, it can affect our speech, our swallowing, and even our thinking, because there are some processing things that go through the cerebellum as well as the other parts of the brain. And for some patients, all we know is that the MRI image looks abnormal, and I'll show you some of those images in a bit. And the patient may have no problems with walking or balance or anything like that, but they have these abnormal images on the MRI. And unfortunately, we've kind of called all of this neurodegeneration, and it creates huge anxiety among everybody, and it should, because it sounds terrible. And it doesn't absolutely mean it's going to be terrible, but we only know by following these patients for a while to see what goes on. So one of the things that we've noticed over the years is that the images are something like the images from patients with multiple sclerosis, and those patients have problems with balance and thinking and tremors. And we've been able to use some chemotherapy treatments such as cytarabine or Ara-C to help some of these children and adults if we find this balance and tremor problem fairly early on. If we get the therapy started quickly, then we usually have moderately good success. And there are other things that are used too. Some of them don't respond to these usual drugs, and we've done some further exploration that I think Carl's going to tell you about, that we found really the cause of this syndrome. And I'm not going to steal his thunder, but I'll just say there's a specific drug called vemurafenib that helps with the problem that Carl's going to tell you about. And some people use intravenous immunoglobulin, or IVIG. It may make the patient stable, but it doesn't really cure them. Well, recently, in face of frustration by not having the usual things work, I started using a drug called rituximab. And it's not a chemotherapy drug, but it's called a monoclonal antibody. And I'll explain more about that in a minute. So these are the typical MRI images of one of our patients who's actually been afflicted with this neurologic problem for over 8 years. And this whiteness up in this part of the brain and back here in the cerebellum are the classic images of the neurologic syndrome of LCH. And this boy has had problems with balance. He couldn't do a finger-nose test where you go between your finger and nose. He was like this. He couldn't balance on one foot. And he started having some really, really unpleasant antisocial behavior issues and failing school, and his parents were just at a loss. And I tried all the other therapies, and they weren't working, and so I tried the rituximab. And the next patient, MRI images really are kind of normal. There really is no whiteness where there shouldn't be whiteness. It really is a normal brain MRI. But this young lady, about 15, had problems with tremors, not as bad as the first patient. And she had a lot of learning difficulties and really wide swings of her emotions. So she was kind of in a bad state too. And having tried all the other things first, they didn't work, and then I tried the rituximab. So in the next slide, just want to explain a little bit about this disease, LCH. You know, we talk about the histiocyte, but there are really a lot of other cells that are involved. And when you look at a biopsy, there are lymphocytes that are the T cell variety, the B cell variety. There are the histiocytes, or dendritic cells. And then in the brain, we have some white blood cells called microglia, which probably come from the macrophages in the first place. But all of these cells could be doing something wrong to cause the brain to be damaged and for these patients to have these problems. And some of the therapies for these neurologic conditions really get at protecting the nerves. So the question is, what does the therapy do? Does it attack a bad cell, or does it just protect the nerve cells? So the next slide, I just want to remind you that besides the images being similar, we found a protein in the spinal fluid of these patients called osteopontin. And we already knew this was an important protein in LCH because in 2010 we published a study showing it's the most highly upregulated gene in LCH. And we're still exploring its impact in the disease, but we know it's important in the immune system to call in cells of the immune system to a problem area and to help regulate inflammation. One of the things that we don't see a lot of in these patients are B lymphocytes, but the B lymphocytes are important in multiple sclerosis. So there's some parallels here, but it didn't quite all add up. So in the next slide, just to tell you about a little bit about why rituximab has been used in multiple sclerosis, because we know the B lymphocytes are making antibodies that are destroying the nerves. And so if you take away those B lymphocytes so they don't make the bad antibodies, and the nerves are protected. The rituximab does some other things to the immune system. It quiets the way it interacts with some other cells. So it seemed like this might be a reasonable therapy for LCH. And just next slide, just to kind of show you what's meant, the CD20 is a protein on the surface of the lymphocyte, and just blown up view, it's this green squiggly thing is a representation of the CD20 molecule. And the rituximab is an antibody that binds specifically to that CD20 protein. And it's very, very specific. And so there are these CD20 molecules all over the surface of the B cell. So if you put rituximab on it, then it's just going to glom onto the surface of the B cell and damage it. And these are some of the other ways that the B cell interacts with monocytes and with complement and with some signaling pathways of the cells. So there are many things the B cell is doing besides making the antibodies, and by taking away the B cell, then you can kind of quiet the immune system. And so for malignant B cells, like a patient with a lymphoma, you bind this little purple antibody on the surface, and it takes away all these B cells, and the patient can go into a partial remission just from this one drug. So one of the problems with this central nervous system issue in LCH is that despite giving the patient some of the chemotherapies that help treat other aspects of the disease, this neurologic problem can progress. So when they're on vinblastine and prednisone or even 2-CDA, we've seen these neurologic symptoms develop. A long time ago, a group of investigators used transretinoic acid. Maybe it kept the patient stable, but nobody's used it for over a decade. And as I mentioned, intravenous gamma globulin just kind of coats a lot of cells and may make these patients more stable. So what we have now accumulated is experience with 7 patients And these are all patients who are at a higher risk for getting the neurodegenerative condition because they have lesions of the bones around their face, their eyes, their ears, the sphenoid bone that's deep inside our skull. And a lot of them, you see 5 out of 7 had diabetes insipidus. So once the pituitary gland is affected by LCH, then there's a greater chance that these cells can get into the cerebellum. And we had an idea some years ago that there was kind of a pathway inside the brain that would carry these cells from the pituitary to the back part of the brain, but Carl's going to tell you about a really important discovery made that kind of changes all that thought. So the interval between the diagnosis of LCH and neurodegeneration ranged from 1 to 8 years. The symptoms these patients had were the typical things: balance, unclear speech, tremors, and 6 out of 7 had really significant behavior developmental problems that really terribly impacted their ability to go to school, to have friends, to be nice kids in the family. So they were really, really damaged in significant ways. Some of the things that went on were lying and inappropriate remarks, failing grades, decreased memory. One girl had kind of an out-of-body sensation. She felt like one half of her body just wasn't there, and she had some funny tingling sensations. One child had staring episodes where he just seemed to be perseverating on one thing and just staring at some object. And several of them were socially withdrawn, which is not surprising because their interactions with their peers were so abnormal, they had no friends. So in the next slide, what we found was that 6 out of the 7 had improvements in their balance and their tremors and their speech. And we had tried 1 to 3 therapies before this that had not worked. And the really vexing thing about this condition is that sometimes you start treatment, it seems to work, and then it doesn't work. And we try to increase doses of chemotherapy, and that may or may not help. But I think this rituximab may be a nice addition. So learning and behavior problems, 4 out of 7 responded, 2 of 7 had no change, 1 was probably just the same. So our major challenge now is to figure out how does rituximab work, because we really don't have a clue. We've looked for abnormal antibodies in the spinal fluid that would attack nerves, and as yet we haven't found them, but I think we might need to dig deeper. We might think of combining this rituximab with cytarabine, and maybe we would have a better outcome. And of course, the problem with all these therapies is how long should we give it? And the rituximab has some real significant issues with it. Some people have bad allergic reactions. When you take away the B lymphocytes, then you lose your responses to immunizations, and your ability to fight viruses is decreased. So they're at increased risk of infection. So as yet we haven't come up with a fixed time period, because when we stop it, it seems the patients get worse. In fact, we've even increased the dose recently and had a much better effect. So that's kind of an update on the neurologic issues with rituximab. Carl's going to hit on another important thing we've discovered this year. But at the Family Day in April that we had in Houston, I just gave a presentation about the confusing rashes of LCH. And when you see these pictures, you can understand why a lot of patients go back to the pediatrician for weeks and months, and because the rashes look like common things that kids get. And you really have to be at a point where you say, I've tried enough therapy and this has been too long, we need a biopsy. So just looking at the rash, you really can't definitely say what it is. So the first picture, I think, is a cradle cap, and this is something that newborn babies often have, and it can be really pronounced with lots of scabby white stuff all over the scalp that eventually resolves by about 2 months of age. But if it doesn't resolve by 2 months of age, I think that the patient should have a biopsy to see if it's LCH. So the next picture is not quite as dramatic, but it's kind of the same issue. It's scaly, brown and white, flaky things like really bad dandruff on the scalp, and this is one of our patients from years ago. And there's another one in the next picture, not so dramatic, but the scalp rashes of LCH can be as insignificant as that. And that may be the only way you can diagnose it. For instance, if a patient had pituitary involvement, you couldn't biopsy the pituitary gland, and you biopsy that little rash, then you'd make the diagnosis. So it's important. One of the other terrible common rashes of children is seborrhea, and this baby has all these pimples on his face and that scalp and behind the ears, and rashes behind the ears are pretty characteristic of LCH too, but it can be seborrhea. So in the next picture, we have another patient with seborrhea, and in the next picture, we have a patient with LCH. And for all the world, this could be seborrhea. It could be a staphylococcal infection. Probably it could be some other things, but after all the antibiotics and creams didn't work, this child had a biopsy, and then the diagnosis was made. Dermatitis caused by the Candida or thrush fungus is pretty common in babies, and this is what it looks like on the left, but on the right, that's LCH, which looks for all the world the same. And the next picture is a baby that could have had a diaper rash that just got worse and grew up his chest and abdomen, and this turned out to be LCH. Psoriasis is another common rash of children, just kind of a nonspecific red inflamed area, often in skin fold areas in the armpits. Sometimes it makes scabby, scaly things that could be anywhere in the body. And then next comes LCH, which this was a horrendous rash a baby was born with, and you can see how it looks like a common rash, but it certainly wasn't very common. The next one is a little baby with congenital cytomegalovirus infection, which is, of course, a very dangerous thing for a newborn. And there are lots of those purplish little spots on his cheek, but sometimes they're even more dramatic, and a child can be completely covered with it. And this patient was born in the south part of Texas and was in a hospital for some time because they thought the child had a congenital viral infection, CMV or herpes, but then when they biopsied this, it turned out to be LCH, and she had involvement of the liver and spleen and the bone marrow, and she was treated, and now she's just fine. I think she's about 8 years old now. Here's an LCH rash that it's kind of typical for not only children, but for adults also. They can have these flaky red pimple-like things anywhere on their body. And this is an unusual LCH presentation between the toes. We sometimes see it next on the finger, well, up in the mouth. So oral involvement can be really often for babies and for adults. And I'm going to show you a bunch of pictures of children who have involvement of the soft tissue of the mouth, maybe the gingiva, sometimes inside the cheek or on the tongue. They can have these ulcers. And this is a baby who came to us with, a lot of ulcers in his lips and I think over infection as well as the ulcers. But it turned out to be LCH. And sometimes it's a little more subtle, just an ulcer up on the roof of the mouth. And the next one is one of the most dramatic ones I've ever seen. Look at fungating tumor coming out of the top of this baby's mouth, and his teeth were all kittywampus, and he's responded very slowly to therapy, but he is getting better. And sometimes the gingiva are involved. This is one of my adult patients who ultimately lost some of her lower front teeth, and I have a fair number of adult patients who've lost all their teeth because the jaws have been involved over many years, and the dentist just can't do anything to cure the problem. So I think maybe we'll just stop there. This was a study we did that showed that skin involvement is really important, and some patients come in with the idea that it's skin only, but if you dig deep, you find they have other areas involved, and that's very important because if they have other areas involved, you obviously have to treat them. And if they have other areas involved, they often don't respond to the first therapy. So it's one of those problems we still have to solve as to what would be the best therapy for these patients up front. And Olive will tell you about a study that we've started to compare cytarabine to vinblastine as the first therapy. So I think I'll wind up my part and see if you have any questions.
You commented in one of the slides there's a diagnosis of your survey of patients between the ages of 2 and 21. So I'm curious, is that because symptoms didn't show up till then, or because symptoms were there and we didn't know it was LCH?
I can't remember the specifics, but it can be either, because some patients can have these symptoms for a very, very long time, and nobody recognizes the cause of it. Sometimes these neurologic problems kind of emerge in what you think is a stable patient, then all of a sudden they've been stable for years, and then they develop this new problem.
How much does it cost to do an LCH test now?
The BRAF test?
Whatever test you use, I don't know.
Well,
It's a couple $100.
yeah, just the
$200.
molecular test is a couple hundred.
Make my path group, we'll do it. Very good.
The circulating.
Yeah. This is the blood test now?
Right.
Yeah.
Yeah, well, we routinely do the BRAF analysis on all of our patients.
So it's a pretty low bar to run a test then, like if you see any sort of symptoms, you can run a graph
It's,
test.
you know, it's helpful 2/3 of the time, but that means that 1/3 of the time we're looking for other things, and I don't know, you're going to talk about our filling in that pie chart with the other, yeah.
And those kids with the neurologic, are they having seizure disorders?
No, that's very rare, having seizure disorders in LCH. I think I've only seen, well, they're a little bit like absence seizures or petit mal, but they don't have EEG changes that are characteristic of that problem. So some of the kind of the clinical presentation is similar, but it really is not neurologically or electrophysiologically the same.
Can I ask you
Yes.
about the MRIs where you see changes? Is it only in the cerebellum where you see changes, or could changes in the prefrontal cortex also be in an
Very
indication?
rarely in prefrontal cortex. It's the mesotemporal lobes, that picture on the left I showed you where there was some whiteness kind of just behind the frontal cortex. And then when it affects the mesotemporal, it's really serious because these patients really have a lot of problems with cognition and behavior too. And it's usually pretty well set in. Once it gets there, it's hard to reverse it.